Well, good afternoon and welcome to today's or CAF's weekly COVID roundup. You've joined the CAF Disaster Preparedness Program. Today is August 21st, 2020. It's 1 o'clock in the afternoon. And my name's Jason Belden. I'm the Director of the Emergency Preparedness Program at CAF. Today we'll have a guest speaker, Deanne Walters, CAF's Director of Clinical Affairs, and we'll go over some of the stuff that we kind of talked about last week, but we really want to kind of focus in on the communication issues. So Deanne's going to talk for a little bit about some of the stuff we're hearing from all sides, from the ombudsman, from CDPH and other folks. So we'll get to that a little bit later. To start off this week, we're going to concentrate on a couple of different AFLs. Now, I don't have a ton of information as to, if you have a significant desire to do dialysis in your skilled nursing facility, we now have an allowance for that. There's an AFL that describes it in depth. It's not as simple as just starting up dialysis in your building. You have to have an agreement with an ESRD provider or a dialysis clinic. It's essentially, we've argued for years that, if dialysis can be done in the home setting, why couldn't it be done in a SNF setting? And I think this is, the entire coronavirus pandemic has forced folks to look at, ways to optimize not having to move folks around, and especially given the fact that dialysis is folks that go out to dialysis become a vector for transmission of virus into our building, and consequently it could be the opposite way, where they could then affect other folks at the dialysis facility. So if you guys are interested in learning more information about that, I highly suggest clicking on the link and reading through it. We do know there are a number of providers that are well advanced in this and have been advocating for this for many years. And so now will be your opportunity to jump on that. So that's good news. The second AFL that came out this week is much more timely, and it definitely relates to the current COVID pandemic and how we respond in evacuation scenarios. And I'm going to go over this in depth because, gosh, it's not, you look at it and you go, what's the likelihood that I have to evacuate? And I realize it's relatively small, although just because we're in wildfire season doesn't mean there's not other reasons that could cause you to evacuate. So we'll cover that because there are points within an evacuation that are different, or that we have to have different considerations during the current pandemic. So we'll talk about that at length right now. I want to say that the way that CDPH wrote this AFL, they wrote it to basically give two different kinds of facilities ideas of what to do in the instance of an evacuation. So one, we're going to talk about evacuating if it's you as a facility, and then the second part will be if you're receiving evacuees, what are your responsibilities and kind of what questions you should be asking, things like that. So much of this is built on our traditional evacuation plans, for transportation, for communication. A lot of those things are going to be the same. All we're going to do is we're going to communicate with the folks that are assisting us in the response, and whether that be ambulance service or wheelchair buses or anybody else that's assisting, it will be there will be a portion of this where we have to communicate the kind of the limitations and the risk and exposure risk for the responders that are responding. So we'll talk about that. But it's really important, and hopefully you guys are well versed in this now. It almost makes me want to ask a question in the chat box to see how many of you guys are on weekly calls with your healthcare coalition or your local health department, or some kind of collaborative weekly or biweekly working call to talk about COVID and its effects on the health system within your county. If you guys are having those discussions, that is a great place to kind of say, okay, we've got all this. We see half the state is on fire and Southern California hasn't even started now. What are our planning ideas, and how are we going to move residents or patients or clients around if we have to evacuate them? So begin that discussion with them if they've not already had it. And it's better if it's the entire healthcare continuum on those calls. If you have hospitals represented and all those things, that would be great. If they're not, and if you guys are siloed off and you have your own kind of planning calls with your counties. I know many counties do this, not every county, but many counties do this. And on those planning calls, if all of the healthcare spectrum is not represented on those planning calls, I would ask the folks from local health to say, hey, listen, can we include the hospitals? Because they may have a bigger role to play during an evacuation of a COVID positive facility, or folks with COVID positive residents. So I want you guys to raise your hand and say that in those planning discussions, because that will prompt those folks to go, oh man, okay, how many positive folks do we have in SNFs now? Where are those open beds if we need to move COVID positive people around? They're going to have that discussion with themselves and to look at the whole system in terms of by cohort categories, how many available beds are. Now, one of the recommendations that we had to CDPH was, we're doing daily polling. Could we add a question in there that just asks, what the availability is in each cohort section? So there may be a couple of changes to the daily reporting just to add in a couple extra questions about that. Now, by you answering that question does not automatically mean they're just going to send you folks. It just means that from a 10,000 foot view, the county can say, we have no beds, we have 100 beds, or we have 400 beds. And they'll be able to go, okay, I can take 20 evacuees. I'll start calling facilities to see, how many they can take and in what cohort zone. But it's easier for them to be able to respond to regional efforts where evacuees may come across county lines by being able to see that information. So if there is a change to that survey process, this is one we should all actively participate in, even if it adds a couple extra minutes of extra work for us. I do think it's important for those folks to be able to see that. If you've not already established memorandums of understanding or memorandums of agreements, I would, you can do it during a response. You can even do it after you've completed an evacuation, once you find out the evacuation location. The problem is you wouldn't get to dictate those terms unless they were pre-defined before the event happens. So you may find that somebody is hesitant to sign that agreement after the fact. So my suggestion is, if you've not already done this, hopefully you guys are well established with having MOUs or MOAs with other sister facilities or facilities within your geographic area. That's important. I would also use those planning calls as you talk to your counties to say, I don't have MOUs with everybody. Now, there are certain counties that have a countywide memorandum of understanding or a memorandum of agreement that kind of dictate the terms of transfer and discharge and all of that stuff. Santa Clara has one, San Diego has one. I believe there are a few other counties, but those are kind of overarching agreements. We're not talking about a contract or a legally binding document. These are documents that kind of lay out the format of what you do in an emergency response. Who's going to pay what? Who's going to send what? So it dictates, we're going to send staff, we're going to send supplies, we're going to send medications. We're going to send medical records. It lists all of that stuff in the agreement. The main thing we want to kind of harp folks on is if you've not been involved in an evacuation or you've not received evacuees from an evacuation before, the one thing we want to note is you guys don't want to discharge these residents. Unless you anticipate it's going to be over 30 days, you lost the building caught on fire, whatever the case is. If you anticipate you're going to be out of the building 30 days, and if you're evacuating for a fire, let's hope it's much less than 30 days, but you're going to just have a temporary transfer agreement where you're going to pass through that rate, or you're going to reimburse that facility for whatever the rate is that resident gets paid at. So if they're a Medi-Cal, that's the rate you're going to reimburse. If they're Medicare, that's the rate you're going to reimburse. Private pay, it goes down the list, but it basically lists those things out, but it's not a contract. This is a handshake agreement. It's not legally binding, but it will kind of put the terms in writing so that folks know what they're agreeing to. So, and then go back and look at the current agreements you have. There may be administrators or contacts for these other facilities that you have listed that are no longer at those facilities. So we want to make sure they're current and we have the appropriate contact information for the folks we have the agreements with. If you've not already done this, we strongly suggest you modify the existing evacuation plan that you have in your emergency operations plan to include infection control measures. And when we're talking about that, I want you to think in terms of how we evacuate. Normally, we kind of have a staging area out front where we're awaiting transportation, provided the staging area is safe and it's not 120 degrees outside and blasted by smoke. It may be safer to stage in a portico or an alcove or somewhere inside the building, but we're going to have a staging area. And normally we would start to stage people based on what transportation resource they're going to go on. And when we're talking about in a COVID environment, we're going to want to do this differently, and we're going to need to phase how we move people out of the building if you have folks that are either in the exposed or quarantine zone or in the red zone, because we know all of those folks in those two cohort zones, everybody's wearing full PPE when they're providing patient care. And so when we do that, that will also help the responders or whoever the transportation resource is to know, what precautions they need to be wearing when they're proceeding with that transfer. And that a part of that will require you to communicate with the MOOC to tell them, I've got 16 reds or however you want to term it. I've got 16 COVID positive folks that need evacuation. I've got 14 COVID suspect cases or cases where we're monitoring them. And then I've got 37 green or no known exposure and a negative test. And so we're going to need to communicate that with everybody that's going to be involved, because those responders, whether it's an EMT or somebody else, are going to want to be wearing full PPE when they do the transfer of those residents. We're going to communicate with the receiving facility. Now, we know a number of facilities, not a number, but a few facilities have started the process of evacuation due to the Northern California fires. And what we learned was that if you're a part of a larger chain and you're having census issues in your other areas, you may be able to manage this entirely internally. Maybe not the transportation part, but you may be able to find placement for those residents internally. And that will make it much easier for you guys to do the evacuation. But if you do not have that capacity, you need to clearly communicate with the receiving facility the exact resident count by cohort category. Now in the AFL, they're asking you to really do 3 or 4 separate categories. They're talking about cohorts. So positive, exposed, meaning those people that are currently undergoing serial testing. So if you pop the case and you're in the process of doing serial testing, that is what they are calling exposed. And then you've got the new admits, which are on that 14-day hold. And then you've got the negative with no known exposure. And then they want a separate category to be kind of any residents with test pending. And so maybe that's a separate category, but clearly communicate that information. All right, and so that's, whoops, sorry, I keep scrolling too far. All right, and so that's for the sending facility. And we'll talk about tools in a second here to get you through if you're looking for, kind of toolkits or templates to use. We've got some of those, and I'll share those in a second. So if you're a receiving facility, you're going to communicate your space availability by cohort, right? Now, you're probably going to be, well, not probably, but you're probably already suffering from staffing issues. And if you're not, that's great. But if you are, be mindful that when you communicate with these folks, what your staff availability is. It's the expectation of the evacuating facility to send staff that are needed. Now, my hope is you're not getting one resident, because it's really hard for them to send one staff for one resident. But if they're sending 6 or 8 or 10, then yes, they should be sending staff. So communicate with your staff availability. If you have the availability to staff that area because your census is down and you have enough staffing, you can communicate that as well and tell them, I have a surplus now, but maybe tomorrow, can you have staff show up here? We're going to request and make sure we're getting medical records, medications, obviously, supplies for residents, including PPE. We want them to come with whatever's appropriate for their cohort category. And we know if we're evacuating those folks, we want them at a minimum to be wearing source control when they're going through the evacuation. And if they're positive, we want to encourage them to, make sure that the mask stays on. We don't want anybody getting sick during this response. If you're a receiving facility, you're going to designate an area where you can receive and triage these folks. So whether that's outside, depending on the weather, it could be outside, it might be inside in, kind of a set aside area or your entryway, but designate an area where you can receive the residents and triage and make sure that everybody, the go bags have everything in it, and ensure that the staff and supplies, have made it. And then we're going to put residents in designated spaces by cohort. And we're going to be really mindful about which, now hopefully you've got 2 distinct entrances where folks that are working on the red side and folks that are moving in and out of that portion of the building are have a separate entrance. And if we do, we want to make sure that we keep those folks that are in that cohort category going through whatever the same procedures are that you have for bringing in a new COVID person. So if you have separate entrances, let's make sure that we use those. I would, I'd be cautious of polling anybody that's a COVID positive through areas of the building where it's going to expose them to folks that do not have COVID. So, and we just want to be as mindful as we can. And I didn't really mention this on the sending facility, but when you're evacuating residents, my suggestion is to, evacuate them by cohort category and save the folks in the red category for last, because you don't want to move them through the building causing, potentially infectious disease in the air, where you're going to have folks that are not exposed and bring them through that same area. So unless, it's an immediate risk to life safety of the people in the red zone and you have to get everybody out of the building, I would try to phase it where the folks in the red zone are the last to leave and the folks in the green zone are the first to leave. But that will be really dependent on the nature of the emergency and how quickly you have to get out of the building. All right, so let me get back to the receiving facility. Any symptomatic residents who have not yet been confirmed with a COVID positive test, say they're symptomatic and test results are pending, those are the folks that we want to prioritize as the first people that would get any single occupancy rooms if they are available. That should have its own asterisk, but if they are available. So, but if you have some available, that's how you want to prioritize who gets the single occupancy rooms. And then obviously, you know, we're doing the same cohort in our mitigation plans that we already have in place. And if there are limitations, don't, you know, if taking an evacuee is going to put the life safety of your current residents or staff at risk, then you should not be saying you can take evacuees. We should only do it if we can do it in a safe manner, and you're going to have to evaluate that on your own. But just know that the hospitals really don't want to see, you know, unexposed nursing home residents come to the nursing home and then get exposed. And so none of us want to see that. So the green zone may be really easy for us to find, but I just want you guys to make sure, prioritize the life and safety of your own residents and staff first. But if you can safely provide surge for another nursing home, absolutely. We love folks that help out, because that's a real big help for the folks that are evacuating. All right, and so some other considerations, we'll talk about the evacuated staff. So we talked about staff going to a facility. Any staff that's negative for COVID-19 may work in another facility. And as long as they're screened for symptoms and implement source control, doing all the same things that they would do at their home facility. And in the AFL, it does talk a little bit more at length about what to do if somebody tests positive. And it's a really kind of nuanced perspective. I didn't want to get into it because it would take me even longer to explain it. And I just wanted to say that, yes, they can work. They'll be subject to the same kind of procedures at the other facility that they were at their current facility. All right, so what are some tools and templates, and how can I update my evacuation plans, you know, things like that. So on the CAF Disaster Prep website, this is separate than the CAF website because this is a grant-funded website by CDPH. These tools are freely available for anybody in the general public to use, but they're mainly designed for skilled nursing folks and to some extent in the assisted living space, folks can use some of this stuff. But the evacuation guide is great, but it's a straight evacuation guide. It has no additions for infection control. So we'd have to take that and we want to modify that. If you're looking at, gosh, I've never received evacuees, what does it look like to surge? And what are the questions I should be asking? And how do I track residents in my building? All kinds of stuff like that. Some really great resources on the surge capacity side. Many folks don't know this, but if you do have to evacuate from a nursing home, in order to repopulate back into that nursing home, you need to have a repopulation plan. And that repopulation plan follows a specific formula. And we've got a repopulation plan template on our website that kind of describes the things that you'll need to verify are in working order before CDPH and OSHPD will allow you back in the building, especially as it relates to fire. You know, we've heard stories where folks left, you know, at a moment's notice, and the air conditioning system pumped smoke through the building while they were evacuated, and they came back and they couldn't occupy the space because of the smell of smoke was so pervasive that they had to get a remediation company to come in and take care of it. So it's things like that that OSHPD and CDPH want to verify that the facility is safe to reoccupy. And then lastly, if you're interested in like action guides, guides to dictate, you know, actual specific tasks that you should be doing during evacuation. Not everybody uses NICS or Incident Command, but there are great tools within those, even if you're not working within the Incident Command structure. And at that bottom link where it says NICS or NHICS, we have a ton of tools that talk about that. And one of the main kind of toolkits we want you guys to really focus in on, and it's really, really important, is the master resident evacuation tracking form. So I didn't mention this, but you're gonna be required to track every single evacuee and keep a daily log of where they are and all that stuff. We're also going to track staff, any on-duty staff that are positioned at other facilities, or whether they're at an evacuation center or they're in a staging area. Wherever they are, we're going to track any on-duty staff that have had to leave or evacuate with the facility. So those forms and those toolkits are all within that NICS link there. And gosh, it's got evacuation response guides, and it's got job action sheets, or basically job descriptions for each level of person within an evacuation. It's very detailed, but if you have questions, feel free to reach out and ask myself. All right, so I'm going to cover the CDC Interim Guidance for rapid antigen testing. We do anticipate, probably some more clarity around how to use these point of care testing devices, but this interim guidance is not very clarifying, let's say, for how we will actually implement this in California. But it is important to note, because CDPH will tie in their guidance to whatever CDC is doing as a best practice. And so that's why I pulled this out. And we anticipate this will be in some manner, this will be drafted into an AFL, in which CDPH will probably release about 5 o'clock tonight. That's generally my guess. So we know that, and Dr. Epson and Vicki Keller have mentioned that there's going to be a terminology change. And it seems silly to do this now, but really we've been using the incorrect terminology all along as it relates to surveillance testing. And, I'm not an epidemiologist, but I listen to them. And so they've explained to me kind of the difference and why we call things what they are. And so I'm going to explain just briefly, and then there's a link to the resource that you can pull this stuff up yourself. But definition of a diagnostic test is a test that's intended to identify infection in a symptomatic or exposed patient. That sounds fairly straightforward. An example of a diagnostic test just means we're testing people we think already have it, and this is confirming the diagnosis. Definitions of a screening test. Now, previously we had been calling this surveillance testing, and we've been tried it and told this is actually screening testing is what we're doing. So screening testing will identify infected persons who are asymptomatic and without known or suspected exposure. So that describes the kind of weekly / monthly ongoing testing we're doing for our staff. Or if you're in Los Angeles, that also describes the 10% you're doing for residents. An example, weekly, monthly staff testing. Now, the surveillance testing, that is de-identified data that's done in an aggregate. So a surveillance testing would be something that a public health agency would do for surveillance testing. That's the best way, the easiest way for me to describe it. So you're going to see a difference in language after this, and they're probably not going to refer to things as surveillance testing anymore, since CDC has changed their language as well. All right, so what does that actually mean for us? Well, in the interim guidance, they talk about two separate things. They talk about sensitivity and specificity. Sensitivity of a test generally means how long that test can detect the virus. And so if we were saying that the current RT-PCR, or the real-time polymerase chain reaction test, I'll forget the acronym, what it stands for, but so if we say that is 100%, the two point of care testing machines, one of them is at 84% and the other is at 97%. And so that's 84% or 97% of that PCR specificity. The good news, or sensitivity, I'm sorry, the specificity of both is 100%, which is great news because it tells us we're really unlikely to get false positives from these type of tests. So sensitivity just means how long will we be able to tell what level of virus is in that that specimen. Will we be able to tell it's a positive test, right? So antigen levels in some patients who have been symptomatic for more than 5 days may drop below the limit of detection of the test. And that's based on studies they've done on both of these point of care devices. And so what that means is if we're in a short window where we catch these people while they're asymptomatic, but also in that window where they could transmit virus, the problem is we may not be testing enough that this screening test will catch every one of those tests. And so either they say, A, you use the point of care testing, but you use it every 4 days instead of every 7 days or every 10 days or every 30 days or whatever. The point is, I think it's going to, unless new studies come out to say that it's more sensitive than previously thought, it's probably unlikely that this will be the primary source of testing. So I don't think that's going to happen, but I don't know that for sure. But I think based on this information, it would lead me to believe that I don't think they're going to go to that. And what's, if false positives are unlikely, meaning the specificity of both of these tests is 100%, meaning that it generally doesn't get it wrong when it's a positive. It just may not detect enough of the virus to give it a positive test when it should be. So we'll have false negatives, which could be very dangerous when we're trying to cohort people. So if false positives are unlikely and false negatives are possible, what's the best use? Well, I talked about the AFL. We anticipate probably dropping pretty soon, but I do think the expectation, or at least my expectation, will be similar to what Los Angeles is currently doing for the point of care testing. As I read this guidance, it seems very consistent with what Los Angeles County is thinking of doing. And just as a reminder, Los Angeles County says you can use the antigen point of care testing devices as a screening tool. And if you get a positive case in either a symptomatic resident or a symptomatic staff, then you would not need to confirm that with a PCR test, because you could be confident, because of the specificity of this test, that those are actual positives. So no need to follow that up with a diagnostic test. The remainder of the testing kind of things all would require all the other, kind of processes you could think of needing to do testing, whether it's on asymptomatic staff for surveillance, or not surveillance, for screening, or asymptomatic residents for screening, or asymptomatic residents as a part of a screening process. All of those would all need to be followed up with the PCR tests. The only two that would not would be a positive symptomatic resident and a positive symptomatic staff member. Now, hopefully, if you've got a symptomatic staff member, they're not in the building. So that, unless they're showing up at the building and displaying symptoms, or calling you from home and saying, I have symptoms, they're probably not in the building. So, or let's hope they're not in the building anyways. All right, so those are kind of where we think the point of care testing device is going to go. We do know that we've heard from AHCA that we anticipate CMS will move to a weekly staff testing requirement, and we're actively seeking help from CDPH to kind of mitigate that, because we don't want a scenario where you're doing two different kinds of tests, where you're doing the point of care testing weekly to meet the requirements by CMS, but then you're doing monthly PCR testing to meet the requirements of the state. It's already difficult to do it. One thing to do multiple is going to be really hard. So We've definitely put that bug in their ear for sure. All right, so I want to hop to Deanne. Deanne wants to talk for a few minutes and kind of drill down on the communication issues that we highlighted last week. Deanne, thanks for joining us. Why don't you go ahead and take it.
Terrific. Thank you, Jason, for having me, and thank you, everyone, for being here on our weekly roundup. It's really important to get the most information we possibly can out to as many people so we can make sure that we are responsive to what needs to be done. So we want to talk a little bit more about communication, and I'm really excited to be here to share this. So right now, at this time, right, when people can't come in to visit their loved ones in person, it is creating a lot of anxiety and concern. You know, everybody is like, what's going on? We can't find anything out. We can't get any information. So we really wanted to reiterate to all of you that we need to take a look at, you know, what is the best practice that we can do in regards to communication and alleviating those anxieties that are building up from other people that have loved ones, or even just the community themselves, because they hear a lot of information from the media and other sources that can cause them to have concern. So we want to make sure that what we have in place is meeting those needs. If you want to switch to the slide. Awesome. So we wanted to come up with a few things that you might want to think about that could be best practices for you to take a look at. Maybe just remind yourself like, oh my gosh, I haven't looked at that one in a little while, or just some off-the-wall type ideas that potentially could help improve and enhance the communication from the facility to family members, even to staff, as well as to the community at large. So we know a lot of people are utilizing their website as a way to inform the public, you know, based on, you know, the CMS requirements that we let people know what's happening and so forth. But some of the websites that we are seeing haven't been updated since June, July, early July. And so even if your information that you put on there is still accurate, the date that shows the posting makes it look like it potentially could be old information. So what I want to say is make sure that your website is being updated at least every 2 weeks. And if there isn't any new information to add, just make sure that the date that goes along with that information is updated so that people know that you are giving them the most current information. So we want to make sure that that outward facing side has as much information as possible. Of course, if you have any positive COVID cases, you're going to want to make sure you're updating it much more frequently. We want to ensure that a live person is answering your phone, and we're going to suggest less than 4 rings. I know in a lot of places like 3 rings or less. I remember that in my customer service jobs, right? 3 rings or less. And the problem is, and it is a challenge for us, is 24 hours a day. We are there and we might get calls, whether it's from a doctor or a concerned family member. We need to be able to answer that phone whenever that phone rings, and we need to do so without letting it ring incessantly. And so again, this is just basic customer service best practices. And we can't just rely on our nursing staff after hours to answer the telephone. And I have to be honest, in my days as an administrator, I remember those portable phones that have to have the multiple lines because of the phone system. They were nearly impossible to work. They would always break down. The batteries would always crash. There was always something wrong with them. So I imagine it's probably not any different now. So we're going to have to be a little bit creative in making sure that the phone is there, it hasn't disappeared or walked off in someone's pocket, and that it is functioning. So that way the nurses, if they are going to need to answer the phone, have access to it. The other item is maybe just to make sure that the phone system is working appropriately and the voicemails are up to date with a current person and a current message, and then to set up a response time. So some of the information would be, you know, if I was to call in as a family member, what would I expect to be a reasonable response to my call in question? Am I going to think that, I expect to have a call back within an hour, or would it be within the day? So we need to make sure that we are setting up that expectation with our leadership team, whoever it is that has a voicemail or who can get a little note on a slip of paper that says there was a phone call, and say, this is the time frame we need to be responding to, and making sure to communicate that to the families. If they say, this is a busy time, we are returning calls within 24 hours or 12 hours, whatever that might be, just making sure that we're communicating to them so they know what that expectation is. And it's even acceptable in this time, because there is so much that you're doing at the facilities, to even leave that as part of your voicemail recordings, or the receptionist at the front desk to say, our typical turnaround time is about 12 hours, because we'll want to get the information and verify it before we return the call. Give those individuals the words to use so that the families know they're not being ignored and that they're getting the right support from us. I know no one is purposely leaving stuff undone, because you are busy and the things that are happening in your facility are urgent, and the care of our patients is number one. We do need to understand, though, that the families are desperate for information, and we also want to provide them the good customer service that we can. Next slide. So some things to think about and consider. This is one of those, like we're saying, outside of the box, could something happen? Potentially, here's an idea, maybe having a separate cell phone that's managed by members of the department leadership 24 hours a day. Now, of course, this wouldn't be specific information about an individual that, say their exact care needs or something from their care plan, but someone that the family member outside of the community could reach for generalized information, and that would feel confident that there's a person there who is going to get a response for them within whatever that time frame is you send up. We hear a lot about this robocall stuff, so the messaging that goes out. So if you have that system, or if you don't yet, if you put it in place, make sure that you are consistently doing it. If I hear it once, but then I don't hear it for 3 weeks, is that a one-time deal, or is there other things that are going on that I'm missing? People begin to wonder, right? They get all up in their head and they can't figure out why they haven't heard from you. So just make sure you're consistent. And even if, again, that says, just like your website, if it says no new updates, everything is still the same, then great. Just make sure that that messaging is coming on a regular basis, even if it means no new updates. One really great thing on the quality side is you could take the information from the response times for the message to the return call and monitor that in Quappy to ensure a high level of customer service. Another thought someone had was to assign a staff member to proactively contact families to set up those visits with their loved one on a regular basis. So getting it set up and scheduled, so that they don't have to call in and make those arrangements, that you're proactively reaching out and setting up that schedule that works both for your team as well as for the family member and resident. All just some interesting ideas. We want to, of course, meet the needs of our residents first and foremost. And I know all of you are scrambling, in situations. You are following your processes to make sure that that happens. The challenge being that outside people, families, communities, media, they can't see all the efforts that you're doing. So that means we have to add one more layer, which is this outward communication, and make sure that it's consistent and thoughtful so that we can relieve some of those anxieties out there. So we're going to be developing some communication strategies as well that will be available on the website. And members of CAF will be getting an email with this information sent directly to them today. So that way you can really think about how we can step up our communication strategy and really help relieve the stress that people outside of our facilities are feeling, and show them the great care that we're giving. So Jason, that's about it. So appreciate the time today.
Thanks, Deanne. And I will just say that, both Courtney and I call a lot of member facilities, and we don't necessarily call the administrator. We're calling the front desk line. And over the last couple of days, I've made quite a few phone calls to folks in areas around the fires. And we're working on another project with PG&E to get meter numbers from folks in facilities that they don't have mapped yet. So we've started this kind of calling campaign for various reasons. And I will say that, pre-COVID and post-COVID, there is a considerable difference between what happens when I call for emergency purposes versus what happened pre-COVID. So you guys are doing good. We got some, we do have some work left to go if you follow in under any of these categories here, if you're not doing that stuff. So, but my entire point is that having somebody physically answer the phone can be life-saving. If I call a facility, and I won't name a facility, but I called a facility yesterday that was in the immediate kind of danger zone from one of the fires that's currently burning, and I could not get through their phone tree. And that is a problem, because if they're not aware that that fire is just on the other side of the ridge and I'm the only one that knows that, how am I going to message that to them if I can't get through a crazy call thing? The same applies. Folks have emergency contacts listed at counties, and they assume that everybody has that information. And I promise you, there's no master list of emergency contacts for each facility, or at least one that's robust and is not subject to folks moving from job to job. So it's really important, especially during this time of year, if you're in that wildland urban interface, you got to make sure somebody's physically answering the phone. I'm telling you, it's a really important thing to do. So for customer service, we want to do it, and for life safety, we definitely want to do it. So thank you, Deanne, for joining us. Maybe you can hang out and we can see if there are any questions for either one of us. Is that okay?
I would be very happy to. Thank you, Jason.
All right, thanks. Courtney, are you with us? Do we have any questions today?
Hi, yeah, can you hear me okay?
I sure can.
Alrighty.
Oh, gosh, you know what? I forgot to mention, well, you go ahead and ask the questions and I'll advance the slide. Go ahead.
Oh, I was just going to say we don't have any questions in the question box yet. So if you would like to go ahead and enter them in now. And Jason, why don't you go ahead about the CALOSHA thing?
Yeah, and this is just a reminder. Folks at CALOSHA really stirred up a hornet's nest with the reuse of N95s. Let me tell you, we didn't realize how many people were using the reuse process and the decontamination process. It's certainly an issue here. The problem with CALOSHA, guys, is they're not in the same government agency as CDPH. They're in a different branch under labor, and the two are not normally work side by side. CALOSHA controls labor law for all of the employers in the state, not just healthcare. We're just a small portion of that. But so when they make decisions, it's not like they're asking CDPH, hey, do you think we should do this? They're making the decision based on their practice. And we've brought that up to CDPH and said, this is not realistic. It's really difficult to accomplish. And for those folks that are, that were heavily relying on reuse of N95 masks, I don't foresee a method out of this. I don't think CALOSHA is going to backtrack to say we can now go back to that condition, unless you had an individual case where it was that or nothing. So if that's the case, the folks from CALOSHA want you to call them and ask them and get permission. He mentioned calling the Sacramento office or calling him specifically, the Eric Berg gentleman. You can call their local district offices as well. I believe they have a public facing interface that can assist you with that as well. And then they're going to have a webinar on the use of elastomeric respirators, which are the full face or half face respirators with the valves on them. We showed pictures of what they look like last week, and they look like, gosh, this looks like an Ebola ward. It's definitely a different visual look than a traditional mask. They're going to have a webinar that describes this, and normally I would think, gosh, this is so overkill for us. It just doesn't make sense. But I think this may be as crazy as this is, I think this may be where our future lies, guys. And if you don't know this, there's a piece of legislation currently pending called Senate Bill 275. It's sponsored by Dr. Richard Pan, who's a senator in the Sacramento area, and along with another sponsor, and I can't remember who the sponsor is, but it essentially has gone back and forth, but it would require each of us, each facility, have a really substantial supply of PPE to withstand a pandemic where you're not subject to supply chain failures. So when we talk about this, if there's some kind of, really crazy storage capacity, let's say they said you got to have 6 months of surge supply of N95 masks or respirators, right? That is an enormous amount if they're talking about regular disposable use of N95s. One use, throw it in the garbage. Imagine how many patient care, how many times you're within 6 feet of a resident. And then imagine how many people are within that 6-foot bubble every day. And each one of those times is separated by a disposable N95. That's a ton of masks. I don't have to tell you, you guys know this, but from a storage capacity, just storing massive amounts of supplies becomes the problem. So if this becomes a requirement, a much more kind of financially reasonable method for us to meet these requirements will be with these reusable respirators rather than disposable respirators. So while I wouldn't normally recommend that we all listen to this webinar, it may be the future of what we're required to have on site, or it may be the only way that we can store enough supply is by finding reusable kind of capacity within those types of respirators. So with that being said, don't poo-poo, or don't say I should not listen to this because it's overkill. Think that maybe next year I'm going to have this requirement to have a substantial amount of PPE, and the only way I can store it on site is by going to a reusable one rather than store hundreds of thousands of N95 masks. So that's my push to get you on the CALOSHA webinar, and it is free. It will be dry, but it will at least give you an understanding of how best to use those devices. Any other questions, Courtney?
We do have one question. Someone asked, do you think SB 275 will pass? And
Yep.
also, okay, so yes. And their other comment was, does the government, or I guess the Assembly or the Senate, do they realize the state and federal government are buying all the supplies and us regular Joes can't get it?
Yeah, and so I say yes. I don't know that 275 is going to get approved as the way it's currently written, but I do think, and we have folks that do this for a living, and they know this stuff pretty well, and they can read kind of the direction of the legislature, and none of them have said that this is going to die. Our best hope is to dictate the terms that are accomplishable for you guys, and to make sure that there's capacity that financially you're not stuck with the bill. Those are kind of our things. And I gave the folks at the Senate, I gave them a picture of what it would look like if we were to store 6 months of supplies. I told them it would take 8 full storage units from top to bottom, 10 by 30. So 300 square feet times 8. So that was my estimation of what it would take to stock what they were recommending with the first version. Now, subsequent revisions have reduced that, and we're hopeful that we can get written into it, things like gloves, where we're using gloves all the time. If we have to have 6 months of our normal supply of gloves, that's like, it's like 8 full pallets of gloves. It's a huge amount of gloves, and we just don't have places to store those, or maybe some of us do, but most of us don't. And then they're going to expire by the time we get through all of them. So there are things we're working with the legislature to get this done. And one of the good things about this bill is that there is going to be an advisory panel, and CAF is going to sit on that advisory panel. So we've got that part in it. So representatives from our industry are going to sit on the advisory panel when we dictate what kind of surge capacity is, what can be used for surge capacity, and what could realistically be accomplished. And the last thing I'll say is their plan is to phase this in over a multi-year period, because we don't want there to be a mad rush to meet the supply chain, because this 275 is going to apply to more than just healthcare. It's going to apply to many other different types of employers. All right, any other questions, Courtney?
We have one more comment. They said maybe they should tour some buildings and see the lack of storage in most buildings.
Yeah, that would be, I try to give them, I try to make it as simple to understand as possible. But I told them, I said, really, we're going to have to build or purchase storage units, like storage companies in order to be able to do that. And their suggestion, well, this was early on, and I don't want to be flippant, but their suggestion was that if they're a part of a corporate chain, the corporate portions, the chains may have the opportunity to have a centralized kind of distribution of those resources, and that would be okay. That doesn't help smaller facilities. It doesn't help, one or two or mom and pop or, owner operators. We realize it's not a one size fits all solution for this, even though they try to treat it that way. Our suggestion, and we stand by the fact that we fully believe that CDPH or EMSA or some government entity should maintain a stockpile that we could draw from, but I don't know that it's reasonable or realistic to think that we can accomplish some of these things. And that's why I think the reusable devices are going to be critical in helping us meet that if we can't offset what the total amount is they're going to require. So, all right, any questions, Courtney? I can let people go early on a Friday for once.
That is all we have for now.
Woohoo! Well, we have some guest speakers next week. I apologize. I was going to have them on this week, but we just didn't have time to get everything in. But we're going to do a deep dive on kind of cleaning and environmental services, stuff we have not talked about before, maybe some best practices for your EVS staff if you're hiring outside companies, what to look for, what questions you should be asking for, what kind of work product can you expect from them, those kind of things. So we're going to cover all of that. I've received a number of questions, and certainly it's a pain point and a possible transmission point of COVID in our facilities if we don't clean well. So we'll have those folks on next week. Hopefully you guys get a chance to join us. It's been wonderful having you. Have a great weekend, and we'll talk to you next week.